Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and we're going to use a case I recently saw in our fast track area as a jumping point into discussing Achilles tendon ruptures. The patient was a 53-year-old woman who basically came in complaining of severe pain in her right ankle. She said she'd been walking down the street and then saw her bus about to pull away, kind of ran to get there, and as she took that first step off of her right foot, she felt a pop, a sudden severe pain, and had a real difficulty walking after this happened. Within that presentation are a lot of the classic pieces of Achilles tendon rupture. Often patients will complain of a severe pain without any real trauma. They'll often feel a pop, and some people even describe hearing a sound that sounds like a gunshot. And the reason for that popping sensation or the noise that they feel is associated with it is because of the amount of tension the Achilles tendon is under. Most of these injuries will occur during some kind of a sporting event or some kind of athletic endeavor, and it is typically associated either with a sudden forced plantar flexion or extreme dorsiflexion of a plantar flexed foot. The nice thing about the diagnosis is that it can all be made on your physical exam, and honestly, it only takes a couple of minutes to figure out what you're dealing with. Most of these patients will have a palpable gap or deformity in the region of the Achilles tendon just proximal to the heel. They're going to have weakness or absence of the ability to do plantar flexion. And if you place the patient prone with their feet hanging off the end of the bed, what you'll notice is that the affected side is going to droop. It's going to be held with slightly more dorsiflexion than the unaffected side. If at this point you're not sure of the diagnosis, you can do a Thompson test. We'll drop a link to a video in the show notes, but you basically place the patient in the prone position with their feet hanging off the end of the stretcher. Next, you squeeze the calf of the unaffected limb. And when you squeeze the calf muscle, you'll notice that the ankle is going to plantar flex. When you do the same maneuver, squeezing the calf on the affected side, the side that you think has the Achilles tendon rupture, you'll notice that there is no plantar flexion of the ankle. That doesn't happen because of the rupture of that Achilles tendon. Unlike a lot of the other physical exam maneuvers that we do, Thompson's test actually has excellent test performance and test characteristics. The sensitivity is near 100%, specificity is near 100%, giving a great positive likelihood ratio of near 14 and a negative likelihood ratio of 0.04. This is a really powerful test to use at the bedside. Most of the time, imaging isn't going to be necessary, but let's talk a little bit about the role of imaging in these patients. If you suspect that there might be a bony abnormality as well, you can obtain an X-ray. That's probably what most people are going to do. You can also make this diagnosis with ultrasound, although again, because the physical exam is so straightforward, you probably don't need it. And the gold standard imaging modality is going to be an MRI, not something we're going to be doing in the emergency department. Once we identify that the patient has a ruptured Achilles tendon, the management is actually pretty straightforward. Provide analgesia if necessary, and then you want to stabilize the tendon in the optimal healing position. Most of the time when we immobilize an ankle with a splint, we immobilize at 90 degrees or maybe even slight dorsiflexion. Here, we actually want to immobilize the patient with about 20 degrees of plantar flexion, and we're going to keep that immobilization going for about 4 to 6 weeks. So we are bracing or splinting the patient in a resting equinus position, again, 20 degrees of plantar flexion. And that's really important because it helps to bring the two ends of that Achilles tendon closer together. And actually, some patients can be managed non-operatively. The standard in the past was they all need to go for surgery. But now we're seeing that some of these patients will actually be managed quite well without an operation. Even if you know the patient is going to go to the operating room at some point to have the Achilles tendon repaired, you still want to immobilize the patient in that optimal position, that resting equinus, that 20 degrees of plantar flexion, because again, it helps to bring the two ends of the tendon together, and it's going to actually make the surgical repair easier. I typically will leave the advising on prognosis up to the orthopedic surgeon who's going to see the patient, but what we kind of know from the literature is that if you treat these non-operatively, they heal faster, but there is a higher risk for a re-rupture. If you treat them surgically, it's a longer healing process, but a lower likelihood of having a re-rupture down the line. Before we wrap up for the week, let's bring it home with some take-home points. Number one, Achilles tendon rupture is a clinical diagnosis. The Thompson's test should be applied because it has excellent test characteristics. Number two is that when you find these ruptures, remember to splint the patient in that resting equinus position, 20 degrees of plantar flexion. That is going to improve the patient's outcome. And finally, all of these patients should have a follow-up with an orthopedic surgeon in about a week or so to discuss operative versus non-operative management. And that's all for the Rebel Core Content Podcast this week. We'll be back in 2 weeks for another cast. Until then, don't forget to hop on over to the site, check out all of the great post-mar faculty, and until next time, stay safe.